I'm Lisa Bennett from Hogrove Publishing. I'm an editor here, and I'm sitting with Kim Penberthy, the author of Persistent Depressive Disorders. We released the book in May this year. This is one of the books, the psychotherapy books for in our Advances in Psychotherapy series. Hi, Kim.
Hello.
Great to have you here.
Thank
with
you.
Your book.
Thank you. It's nice to be here.
Yeah. I thought we could maybe begin by, I'd be really interested to hear your story about how you came to work as a clinical psychologist and to, in the end, write this book on persistent depressive disorders.
Absolutely. So I have been interested in psychology a long time. I was the girl in school who heard people's issues and sort of arbitrated for people. So I was interested in human behavior from a very early age. And initially I was studying experimental psychology.
Oh, wow.
And really enjoyed that. I loved the scientific part of it. I did, however, find myself gravitating towards working more with humans versus animals, and eventually went back and got a PhD in clinical psychology. And that was a wonderful marriage of science and working with people. I had the good fortune to have my major psychologist, the major person I was working with through that graduate program, to be Dr. Jim McCullough. And he is the gentleman who developed the therapy that is highlighted in the book, which is called Cognitive Behavioral Analysis System of Psychotherapy. And so through my work with him, I really became much more involved in working with people who suffer from chronic depression, as it was called then. It's now designated as persistent depressive disorders.
Yeah, I must say, in the book, that is something you do really well, is disentangling what was in the DSM-4, how that all changed and came into the DSM-5.
Yes.
And I think it's great how you do that also from an assessment perspective, who belongs to which diagnosis. It's not easy.
It's not, and it is an important distinction. All depressions are not the same.
Yeah.
Absolutely. And persistent depressive disorders really does go into that quite a bit because the treatments are different.
You mentioned Jim McCullough, and that is he developed the method.
Absolutely.
Cognitive.
So he developed. It's a mouthful. Absolutely. So when I was his student, he had already begun this in the 70s, developing a therapy specifically for people with chronic depression, which is what it was called back then. And this is the Cognitive Behavioral Analysis System of Psychotherapy. So it's a system of psychotherapy designed specifically for people with persistent depressive disorders, many of whom also have trauma histories. And we're seeing this more and more in the literature, that for chronic depression, or what is now called persistent depressive disorders, there is this high prevalence of trauma, either childhood trauma or sort of repeated psychological insults that happen during adulthood.
So you distinguish between developmental trauma and shock trauma. So you mean them more from developmental trauma perspective?
Well, and it can be a mixture of both. Most of the trauma that I'm talking about that you would see in persons with persistent depressive disorders are going to be things from childhood. So this would be abandonment, even things like neglect, abuse, certainly abuse as well, over that sort of period of time. So sort of chronic trauma that way. So it is distinguished from something like post-traumatic stress disorder, where you might have the trauma of going to war or being victimized as with an assault or something. But certainly persistently depressed patients may also have that history as well.
Yeah.
Because we do know that it seems that if you are a victim of trauma early, you are more likely to be a victimized again.
Mm-hmm.
So often they have multiple trauma histories as well.
Yeah. And CBASP is very interesting as a method because what I find really, really fascinating about it is it really looks at not just the trauma aspect, but the interpersonal aspect, what effect we have on people.
Mm-hmm.
And could you say a little bit about that?
Absolutely. I think that is really important to comprehend, and I talk more about it in the book as well, that CBASP is an interpersonal model.
Mm-hmm.
And so a big component is that absolutely there's a biological piece to persistent depression, and thus it's important that many of the patients who are diagnosed with this receive medication of some sort. However, there is a big component that is interpersonal based. And what we know from a lot of research is that persistently depressed patients have learned to avoid. They've learned to sort of be shut down, and they then persist in this even after perhaps it's not applicable anymore. Mm-hmm. And many people with persistent depression don't have a good sense of their interpersonal impact on other people. So if you are avoidant and drawing away from people, this has an impact on other people. It typically, what we know from research, makes other people want to move away from you. And it's interesting because persistent depressive patients recognize this, and they will often say, I feel so alone, I feel like people don't like me. And the reality is they're accurate, unfortunately. And so a big component of CBASP is helping people understand the interpersonal dynamics, sort of fundamentally, and then where they are within that. And it's essentially helping them understand that they do have an impact. Many of them feel very helpless and don't feel like they have an impact, and yet they do. And so if they can own that and learn interpersonally how they are impacting people, and then make changes, learn different strategies to interact, they can be so much more effective. And in fact, in CBASP, that is one of the two main components that we focus on in CBASP. The first being felt emotional safety. Because so many of these people have trauma histories, they have learned to avoid because they don't feel safe. So a big part of it is initially that, helping them feel safe emotionally by using the relationship with the therapist. And the second is this perceived functionality, is setting interpersonal goals and understanding how to work towards them, and then ultimately achieving them. And if you do that, that's what we would call perceived functionality. I am functioning effectively and I understand why, and I feel ownership of it, then it's almost impossible to stay depressed.
It's really about developing self-efficacy.
Yes, absolutely.
Absolutely.
In that interpersonal domain.
Yes.
And many of them can relate to that because they've been able to do that in other areas of their life that are not people related. So, many chronically depressed people may have jobs. They may have things they do and feel efficacious about it. It's typically not with another person though.
Yes. Yeah.
And so it's taking those skills and helping them apply them to people interpersonally, and understanding the impact so that then they have more autonomy in how they want to impact people.
Well, and the way I've understood it is also that self-efficacy comes also from understanding what belongs to the past and what belongs to now.
Absolutely. You're so right. Because many of these people learned about relationships from their traumatic relationships in early history, they learned that people are not safe. And so we are teaching them how to be more effective in this time period, now, current. And so you are working always to distinguish, help them discriminate what was the past and what is now.
Mm-hmm.
And I think that is a lesson that we all can use. Yeah. It is a kind of mindfulness in a way of the present moment of, okay, my urge is to react this way because this is how I've always reacted in this situation. And yet, what we're trying to teach is to be at a place where you can be intentional and mindful and say, wait, this is different. And there might be different possibilities
Mm-hmm.
now. So perhaps I could act in a different way with more of an assurance that it would go differently.
Yeah.
And it is teaching that in a very systematic way that CBASC does. And that is the piece of the interpersonal component that you're talking about.
Yeah.
I think that is very different and very effective for this kind of therapy.